အားလုံးပဲနားထောင်နေကြတဲ့ဆရာကြီးဆရာမကြီးများနဲ့ကိုမဒီကိုမတို့များအားလုံးမင်္ဂလာပါရှင်ကျမကတော့ Grand Hunter ရင်မုံအေးပါရှင်ဒီနေ့ကျမတို့လုပ်ရတဲ့ presentation လေးကတော့ဆရာကြီးလားဆင်ကျမတို့သင်ပေးနေကြ CME Talk မှာပြီးခဲ့တဲ့လအဆက်ဒီနေ့ခေါင်းစဉ်ကတော့ High Floor Cerebral Vascular Malformation အကြောင်းလေးသင်ပေးမှာပါရှင်ပြီးခဲ့တဲ့လဆရာကြီးသင်ပေးခဲ့တဲ့ Low Flow Cerebral Vascular Malformation အကြောင်းကိုလည်းကျမဆရာကြီးရဲ့ talk ကို YouTube မှာတင်ပေးထားပါတယ်ရှင်ဆရာကြီးနာမည်လေးရိုက်ပြီးတော့ကျမတို့ Google မှာပဲဖြစ်ဖြစ် YouTube မှာပဲဖြစ်ဖြစ်ရှာပြီးတော့မှနားထောင်ပြီးတော့လေ့လာတင်နိုင်ပါတယ်ရှင်အားလုံးပဲကျေးဇူးတင်ပါတယ်ရှင်ဆရာကြီးမှာစပြီးတော့သင်ကြားပေးပါတော့မယ်ရှင်
အားလုံးမင်္ဂလာပါဒီနေ့နော်ဆရာတို့ဒီလိုက်တော့နော်ဒီလာဆက်the topic of high flow cerebral vascular malformation ဒီရပါတော့ပြောတော့လာတော့ဆရာတို့ဒီမှာတော့ low flow မှာဆိုလို့ရှိရင်အချက်နဲ့ပြောတော့ဒီနော်အဲ့တော့ဒီပြောမယ့် topic ကတော့အချက်ကြီး၃ချက်ပေါ့နော်တစ်ခုကတော့ဒီNumber one, cerebral proliferative angiopathy. Third one, fistula. The primary AV malformation is that. Typical homogeneous solution, no. We have homogeneous solution normal artery. You know, capillary wall. Then the fact that the anatomy of the basic, not the normal anatomy or histology. Okay, if you see this diagram there, there's a feeding artery, and you get the anidus, anidus and the draining vein. By looking at this one, you notice that feeding artery and draining veins are larger than the normal. Okay, so the characteristic of the solution, which is a tightly packed thin walled vessel, no? Not to there is no intervening normal parenchymal tissues. Okay. Now this is another diagram. If you look at it, there's the feeding artery. Feeding artery coming from the middle cerebral branches like M2 or M3 branches there, and you see there are two veins. One is going upwards towards the superior sagittal sinus. That is the vein of Trola, vein of Trola. Trola catina sinus or the top. There are venous drainage towards the top solution or the vein of Trola to comment. Pero how could the send on here? The transverse sinus therefore we just set a draining vein. How much we call it vein of Labebo, LS with Mara, no? Tony Dubia angiogram solution. You see this large feeding artery twimmer, that's one of the characteristics, and you see larger draining veins going down towards the transverse sinus here. And you see there's a dense collection of nidus in between the large feeding artery and large draining veins. This is the characteristic. And you don't see any normal parenchymal tissue in between the nidus. Now, clinical presentation, we all know that the patient usually they come with the neurological symptoms there, but some of them may be incidental finding, about 15% there. And some people, they present with seizures or headaches, and hemorrhage is quite common. About 65% of the time, AVM, they present with the hemorrhage. Now, hemorrhage, it could be parenchyma, it could be SAH, it could be intraventricular. And usually, they are congenital malformation. Location most commonly at supratentorial compartment compared to posterior fossa, which is infratentorial compartment there, and usually they are large, no? About 2 to 6 centimeter in size, and also they are usually one solitary, more common. About 95% of the time they are usually, they are solitary, and presenting age like a middle age one, not 2 to 4 decades, no? Pidoma, sex, male and female sex, same incidence where no like gender direction. Looking this another diagram again here, you see there's one big artery supplying here, and it divides into many veins, vessels here, feeding arteries, many branches there. That's look like in CT, or MR, looks like a bag of worms, bag of worms. Then you see that nidus, tightly impacted vessels there, and you see large draining veins. This is the characteristic. CT, what are you going to see in CT? You see this in non-contrast study, you see a little heterogeneous hyperdense area. Maybe, there's something, happening, in this area there. But when you give the injection there, you see this nidus, quite diffusely, and this is mostly look like a bag of worms in the contrast study there. And also, when you look the CT now, always look for one is bag of worms. Now that is the one features there, looks like a bag of worms. And also look blood pool density, just like the way we look the blood pool density in the hemangioma, like in liver example. And you see that density in the superior sinus, which is filled with blood. See the blood density here, and this is the density almost the same. The two are the same density. That suggests that this is a vessel, not a calcification. This is a vessel there. So look for blood pool density. Always compare with superior sagittal sinus. Okay, and you look this picture again. The same thing. You see this slightly hyperdense, not well defined. You see this density and compare with the sagittal sinus. Another sinus of vessel, and it looks almost like the same. But definitely when you do the angiogram, this is the DSA, that this is the catheter angiogram, not CT angiogram. This is the catheter angiogram. You see much better. In fact, for small lesions there, the DSA is the modality of choice to see the small vessels there. Now, in this case also, you see this, the feeding artery, the feeding artery here, and you see the nidus there, and you see this early draining vein. You see the larger vein, draining vein there. At the same time, usually you don't see this vein, so that suggests that there is a fistula. There's a shunt at this particular region there. So early draining vein, which is larger than normal. And this is the CT. In non-contrast studies, sometimes you see calcification about 25% of the time. But when you give the injection there, as I said before, look back of worms, look back of worms like here, which is the nidus there. Look for the nidus, this is the one, and look for the veins, early draining vein. This is the early draining vein running towards the midline there. Probably is going to be, to join with the superior sagittal sinus. So this is the slightly enlarged vein of Trollard, vein of Trollard. Okay, this is another good example here. And you see this superficial draining vein, and also deep draining vein. This case, you see, draining veins, both superficial as well as deep. Superficial vein, this vein usually probably is go to the transverse sinus, so you can call this as a vein of Labbe. but this enlarged one is the internal cerebral vein. So this particular aneurysm has two draining veins, which is quite important. No, it's quite important there. And you see the nidus here, and this is the volume rather the CT angiogram, and you see this feeding arteries, nidus, and the draining veins. And also another example that is a 4 years old girl. She presented with the recurrent hemorrhage. So as I mentioned before, they present with hemorrhage about 65% of the time. And also in this particular case, you notice that there's a hypo nodule there, hypointensa nodule there. This, when you look up the angiogram, this is a venous angiogram. So in the nidus, you might find, the dilatation of either the arterial side, or it could be at the venous side. This is at the venous side. Okay, so if you see this one now, there is a greater chance of bleeding in this particular patient there. And according to this one now, the venous aneurysm on the venous side aneurysm is much more common. About 65% of the time you'll see there. But on the anterior side, you see this, we call it also pedicle aneurysm. There, it's about 10 to 15% of the time there. Okay, now this patient, present with the hemorrhage, parenchymal hemorrhage, SAH, and interventricular hemorrhage there. When you look the angiogram there, same thing. This is the middle cerebral feeding arteries here. You see a nidus, without intervening normal tissue in between. You see early enlarged draining vein there. Okay. Now the other one is we call it the supratentorial, and it is at the peripheral region there. It is more common. About 2/3 of the time, it is a peripheral time, and about 1/3 of the time, it's a deep location is deep. In this particular case, the location is at left thalamus, and you see this back of arms there. Okay. Now this is a small one. Present with the small pontine hematoma there. You see this little hematoma, bright spot there. But in the angiogram, you see this nidus there. Now this is a small one, less than 1 centimeter. You call it micro AVM. And when you look at CT now, always pay attention these little density changes. Here you see a very subtle density changes there. You see a little hyperdense spots there. And you know that there's something going on. And this density, it's not like a calcium density. It looks like vessel density there. Okay. Now, if you look the MRI on the same patient, you see this back of worms like a flow void vessels. Flow void vessels, they are round and they are linear. Okay. Looks like a back of worms there. So you know that this is a vessel, not abnormal vessel there. Okay. Now, you have to give the grading here now. So depend on the size. So this is your special Martin classification there. The size, if it's less than 3 centimeter, you give 1 score. And if the size is 3 to 6, you give 2 score. Greater than 6, this is a 3 score. So here on size, the biggest one, so you get the maximum 3 score here. Now, venous drainage. If it's only superficial drainage, so you don't give any score there. But if you see the deep draining vein, like internal cerebral vein, deep, and you give a score of 1. And another thing is location. Well, this is an important location, like hearing, smell, those areas, and those we call it eloquent areas there. These are important areas. So the sensory motor area, language, visual cortex, these areas are important areas there. If you see a lesion close to this area, then you give one score there. If they are away from those areas, then you don't give any score. So you can get together 5 points. No? Total score could be 5 points. So based on that, you see the management there. If the score is 1 and 2, solution, they can do surgery. You see, they can do surgery. If the score is 3, then they have to think of other modality. They might do something like embolization before surgery, before resection, that kind of management there. And 4 and 5 usually is no, you don't treat it unless the patient comes in, frequent hemorrhage, sort of the neurological deterioration. So in that cases there, case by case, they do surgeries, one way or the other. No? So this is a management. So that's why you need a scoring for this one. Okay, now you see, how about the results? No? If the score I want to do low score solution, complication rate is 0. No? If it's a 3 solution, score 3 so in surgery law, at least the results got 4% of the time they get either minor or major neurological deficit. No? Score 4 so in 7%, 5 solution post solo. No? Now the kuka the outcome of Bepoma multi vele solution. The score bingo, now the kuka aneurysm, intra neither aneurysm she the la, she the so in that povido pesam macamu, no? Pido aneurysm arteria feeder ma she the la, no? That idea. Now the kuka venous stasis like cerebral edema in McQuagin lega the neither say bema cerebral edema a myaji she the solution result macamu. Okay then. We go to next topic now. Next topic is cerebral perforative angiopathy. This entity is completely different from the classic AVM we just mentioned. No, we just mentioned natural history or histology, or they're quite different. No, now the kuka, no, it's not very common. Now, AVM the most common cerebral malformation, AVM are the most common. Not only 2 to 4%. No, it's not common. Now, premium age are somewhere around 20, 30s, young population of pitted. No, more or less the same. Fits and lame, seizures, headaches, TIA and lame, progressive neurological deficit and lame. No, hemorrhage, in fact, are very rare. Not like the classical AVM. Classical AVM, they mostly present with the hemorrhage about 65% of the time, right? But in this particular disease, there is very little, almost unusual to get infarct or hemorrhage from this disease. Okay, that's a big difference there. Now, the contrast to the very much look like the classical, but classical this one is multi-lobes, very diffuse. Diffuse look, it's very diffuse, or one feeding artery go pome, parietal lobe, temporal lobe, frontal lobe, something like that. No, now the kuka non-enhancing machine, so oriented to the classical back of worms have no, especially flow voids or MRI solution. No? More than one vascular territory, we mentioned it. No, more than one supplying arteria or mostly. No, supplying arteria nakuko pitchin location and diffuse. Frontal lobe, parietal lobe, temporal lobe. No, it could be different. It could be the whole hemisphere may be involved in this particular case. That's why we call it diffuse angiopathy. No, and acute infarct hemorrhage are very rare. Now, the characteristic features about it: large area of parenchymal involvement of entire lobe or entire hemisphere. No? presence of normal brain tissue in between the nidus. There's a difference. Classical EVM nidus are very tight, containing only vessels. No? But in this case, in between the normal vessels, you got normal parenchyma in between the abnormal vessels. No? That is another difference there. Now, another difference is absence of early venous drainage. Venous drainage are two normal picture, no? It's not early, no? Normal drainage, no time, arterial phase or venous phase, no? Nidus is fed by multiple arteries. The feeder arteries they are normal in size or maybe slightly enlarged. Another characteristic features the nidus no margin very very ill-defined because of the contrast puddling, we call it puddling in the nidus. That's why the AVM classical nidus and matu. Classical nidus are very dense. Angiogram low like this, they get very dense with contrast. These are very fake and spread out to the lobe or to the hemispheres there. Okay. Now, example, this case number one, it's 29 years old male, no? With this disease. You see this hematoma here. Hematoma is quite, as we mentioned, it's very rare. And you see this hematoma is very tiny hematoma, not like the other one there, no? So this case present with the small IVH there. But when you look this one now, can we move this one away? Go ahead, okay. So in the angiogram, okay. Now in the angiogram, you see this diffused, no? What looks like a nidus. No, all the vessels there, abnormal vessels there, they are not closely together there, but in between, you might see some gray area, which are normal parenchyma tissue there. And you see, you don't see the large, one feeding artery, early draining vein, so this is the characteristic of this disease there. No? Now, this is the DSA. Look this one now. No, it's very diffuse, margin ill-defined. Now, Jarema, gray areas is sheeted. No, the angiogram. The same thing is here. No, and this one is left side there. Daga internal carotid artery injection. No, catheter injection there. No? Daga external carotid artery injection. And you see this as supply also from the external carotid artery injection there. So blood supply that indicates that it's not only one artery supplying to this disease. Okay. Now case 2, no? Case 2 got 2007 you don't see much now, it's a normal looking there. But in 2014, you see this hyperdense, small, tiny densities, no? See both cerebral hemisphere there, no? Okay, next. Okay, now with the MRI with gadolinium, and you see diffuse, involving both the cerebral hemispheres. You see all those, little prominent vessels. They are abnormal vessels there, but they are not, located in one location. They are not grouped together. You see very normal brain parenchyma in between there. So this is, in some area, you might see a little venous dilatation there. So this is a typical for this progressive diffuse angiopathy there, no nidus. Okay. Now another case 3 example there. So just try to look, this area there. You see something abnormal density, something like the cortical or subcortical, slight hyperdense, subcutaneous area here, there, you know that there's something wrong, and that if you see the density and the density in the folds there, they looks very much like. So this must be the vessels, the abnormal vessel. Indeed, when you give the injection there, you see this very vague issue in between, and there is no draining vein you could see in this case there. No? So this is the typical. Okay, so this is the, as like a DSA injection there, the same patient there. So it's very vague and diffuse, no? Not like one particular artery or one particular vein. This is very diffuse abnormal vessels. Okay, now look this case now, it's an MRI. The whole right hemisphere, you see this is a flow voids, like all worms, no? But if you give the injection, that this is the image you see here, and you see this, you don't see the definite, but you see this internal cerebral vein. There are two veins here, if you look carefully there, but the right side is a little bigger, no? So this one is draining into the internal cerebral vein, right internal cerebral vein here. It's bigger than the left there, no? And you see this straight sinus size car, no? Is bigger there. Okay, so this is the angiogram, margin are very fuzzy looking, very ill-defined, but of course there's multiple, there's a disease. Slightly enlarged, no? Contribute equally to the malformation. No dominant vessels, no? Neither are usually large, mostly greater than 6. The sputtering of contrast material. That's why the margin is very fuzzy in this disease. Okay, next we finish 2 categories now. The third category is the duro. Now it's a duro fistula. No, this is not malformation. This is a fistula. That means that there is a direct communication between the artery and the vein. So that's why we call it a fistula there. And among the venous malformation, this is the second most commonest, no? Dura AV fistula. The first common one are a classic AVM, no? The most common. This is the AV fistula. This is the second most common, Dura AV fistula. It could be Dura, meninges ma layer say shidile, Dura layer ma fistula shime, pure pire, layer ma le fistula shima. So this is the Dura, no? Fistula there. This is most common among the fistula, no? Dura fistula. Now this is the diagram. Okay. Now this is a second most commonest, no? With AV shunting, no? The right communication there. And you see this, usually you see the very faint meningeal vessels there, no? Supplying the area there. And the draining veins, you see the cortical, cortical veins, no? Not very prominent. They are very, very small veins here. But you might see there's a fistula, no? And also the etiology, when you look at it, most of the time they are acquired, no? They are acquired, like a post-traumatic or post-thrombosis, not like the superior sagittal sinus to transverse venous sinus, the thrombosis, secondary fistula polar. Just like one vessel, block vessel, nature collateral vessels, so this is very much like collateral vessels, because most of the time, venous sinus here, collateral polar. So very the same scenario, no? Now location, okay, all sinus is no? Superior sagittal sinus transverse sinus common, no? Size it depends on what could be small or could be large. Okay. Now, don't forget about learning these vessels. So vessels did supplying vessels, it depends on the region. Supratentorial area, solution, external carotid branches. Okay, anterior cranial fossa, she is when internal carotid artery branches, like example, ethmoidal branches to ophthalmic artery. Any more is an lama, not very peripheral. Cavernous sinus area, posterior cranial fossa area, no? That are two different supply vessels. Location transverse sigmoid, they are more common, no? Pidama cavernous sinus area, no? Superior sagittal, straight, anterior cranial fossa, and tentorium. These are the location, no? Look this one again, not this one. Non-contrast CT, CT. What we are seeing here is just a low density area in this region there, and nothing much we can tell about because it's not this is any CT study there. But when you give the injection there, you see some vessels here now. Now some vessels, very small vessels there. But in fact, this is a case, because of the, now these are the vessels. So you see in the catheter, the angiogram probably looks like the, transverse sinus, maybe, or maybe the, what is that, the posterior end of the superior sagittal sinus may be occluded here. And this is a transverse sinus there, okay? So this must be occlusion of the junior sinus. That's why you got these collateral vessels there, no? In the dural layer, no? Collateral, okay. So this too, no? Look at this non-contrast, no? MRI, you don't see very much here now. No? Now, when you look this one now, definitely you see this transverse sinus, not smooth margin like this one. Right transverse sinus margin looks pretty smooth, but this one is margin quite irregular, and also you see some vessels, prominent vessels, compared to the other side there. So you know that there's a collateral, like a fistula, like an abnormal vessels there, because of the transverse sinus part of there. Okay, now look this one now. So you see much better here. You see these vessels in the durameter there. So this is the secondary to transverse sinus occlusion there. Okay. Another case. Now this is right. Transverse sinus occlusion there, thrombosis there, and you see these multiple collaterals in the durameter there. So this is the dural AV fistula. Next is the pia, pia medialemma, pia AV fistula. Pia AV fistula not necessary, due to the thrombosis there, Also, look in the CT, you see this hematoma there. Now you see this as small hematoma. Here's a third ventricular hematoma. When you do the DSA, and you see this, this is a basilar artery, and this is the left posterior cerebral artery. And you see this fistula here. Now this is a fistula, and you see the draining vein. This is an unnamed draining vein. Venous plexus, venous plexus drain like water. So there's a fistula here in this area there. Because of the fistula here, the left middle cerebral artery is slightly larger compared to the right, because the blood is shunting. This is the pia. These are very rare. The dural AV fistula are common, the almost second commonest. This is very rare entity. Another case present with the hematoma there. But when you look only this one now, if you proceed to the angiogram, now CT angiogram, you see this, enlarged feeding artery, and you see this, vessels, abnormal dilated vessels. Now, of course, if you do the DSA, you see very clearly about this fistula. No, this is the fistula of the dilation. Now, this after quality, they embolize this one now and looks very normal again now. Huh? Okay. Okay, another case. Okay, because these cases are very rare. Now, you're not going to see, one case, maybe not one case in your practice, throughout these years there. These, I got it from the literature, because you have to depend on the literature, because these are the very rare cases. You have to learn from somebody else, who got the cases there, okay? So this is also, we have, to give this credit to this, person, about distributing this rare case. Okay, another one present with quite big hematoma is far from the sinus. And they did the DSA, or definitely the middle cerebral artery and maybe M3 branches. You see this vessel feeding out a little larger than normal, and see this a little something, like a venous dilatation there. This is the area where the shunting is. Okay, so after the this patient underwent clipping to embolize malleable, so patient surgically, they put the clip there, and the post angel looks very normal now. Okay, now this is a focus. This one in the right cerebral fissure, not circular sacral, you see the dilated, vessel. So if you're just looking by this one now this is not the subarachnoid space, the arachnoid granulation, to a mass effect sheet there, Pirodima edema sheet, not a venous pouches, but the angiogram, you see this a very large, M1 segment of middle cerebral artery, and this is dilated vein here, fistula, or venous dilatation. It's another PIA-AV. Now let's go to the fourth category, the vein of Galen, aneurysm malformation. Actually, vein of Galen, this is the embryonic malformation. It is not acquired. So actually, the terminology vein of Galen aneurysm, this is not vein of Galen. This is a normal vein. This is the vein precursor of the vein of Galen, which we call it the medium promesencephalic vein. We call it. This is the dilatation of medium prosencephalic vein. This, if this fetus grow normally, this will become vein of Galen. Vein of Galen. Okay, this is a precursor of vein of Galen there. That's, you have to know this one now. And usually location at vein of Galen. This is most common extracardiac cause of high output cardiac failure because of the big shunting of vessel here now. Usually the baby present with the high output cardiac failure now. Heart disease shunting job. Okay. Now if you look at the vessel now, feeding artery are anterior choroidal artery, anterior choroidal artery, posterior choroidal artery, limbic aortic arch, limbic anterior cerebral artery, limbic precursor or embryonic vessel. That is feeding. Receiving a medium prosencephalic vein.
not the vein of Galen precursor. Daga feeding vessels, receiving vein. No? This is the actual pathology of this disease there. No? Anterior carotid artery, as you know, there is arising from the M1 segment of middle cerebral artery to the anterior, no? Anterior carotid. Now to posterior carotid, posterior cerebral artery and number 3 and number 4. Posterior cerebral artery, mama, the chong media, the chong lateral. No? So, Gaga, gonna build a feeding artery, no? The polio piapi. So, the aneurysm, no, they are embryonic vascular malformation. Fistula, gonna build no, vessel phone, the medium, protencephalic vein, no? Dilomio abnormality, this abnormality, they will never become fistula shini the kalapalom, they will never become normally form normal vein of Galen. Muira Kajara Bakule, Muira Kajara, the time by Palama, very large venous pouch here. This is what we call it a vein of Galen malformation. Malformation the thong of counting, no? Aneurysm sign to a malformation to embryonic life malformation pillar. No? So this is the one you're seeing in newborn baby there, no? Medium protencephalic vein. Okay, another look at this, angiogram there. See this. You see this feeding arteries, those feeding arteries here, as we already mentioned here, and this is the pouch, no? This is the medium protencephalic vein, like a big pouch here. There. Okay. Now, next, category is the CCL. We very familiar with this disease entity now. Mostly, this is due to the trauma, no? Usually, skull associated with skull-based fracture there. In case if it's a non-traumatic solution, there must be, pre-existing cavernous aneurysm there. So, and you see, this is the cavernous segment of the ICA, and it has got a few branches here. The purple color the venous sinus, no? Cavernous sinus. Okay. Now, fistula linear sheet. There are 4 types there. The number 1 type is direct communication, the artery with the cavernous sinus. Cavernous sinus, the carotid artery, main carotid artery, they got direct communication. So that's horizontal, no? It's a big flow. Big fistula, no? Second one, artery twala, no, meningeal branches, ne, cavernous sinus, center. No? Pero, now the third category, meningeal branches, external carotid artery, meningeal branches, ne, cavernous sinus, center. So, the B C type fistula should be fistula a small fistula people. No? The 4th category are meningeal branches, internal carotid artery meningeal branches, plus external carotid artery meningeal branches, cavernous sinus, fistula and type 4 look call it. No? There are 4 types there. Now, clinical presentation, prognosis, ectodermal chemosis, progressive visual loss, these are the common, clinical presentation that we see in practice. Okay. How about the CT? Usually we see in CT very clearly. Looking this one now, okay. Contrast study, you see this right and left, superficial ophthalmic artery. No, the size is quite different there. So this is very big, and you see this little more contrast here. So this is the definite right CCF. Okay, right CCF. Okay, next is see this one, and when you look the angiogram, they always followed by the angiogram. You see this enlarged superior ophthalmic vein on the right side, compared to the left. Left is very small, and also you see the density. This one is almost blood profile oppositeဖြစ်သွားပြီဆိုတော့ fixture ဖြစ်တယ်ဆိုတော့ဒီက very bright ကဘာကြောင့်လဲသူက arterial blood ကြီးဖြစ်သွားပြီဟုတ်လား internal carotid artery ကနေလာတဲ့ arterial blood ကသူ့ထဲဝင်သွားပြီ through the fistula. That's why it looks big, and also it looks very bright compared to the normal left. Okay, so this is another case. This is on the left side. The left side, you see this actual images here, big artery. See this in early arterial phase. If you look the coronary artery, the right side is small, and left side you see very dense and big. Okay, now another case. In this case, it's a trauma. You see scabisma, not a fracture here, linear fracture here, non-displaced renal fracture, and you see this edema in the medial rectus muscle there. But when you look at the ophthalmic artery on the right, you see this dense and slightly enlarged ophthalmic artery there. And if you look the MRI, even without contrast, the background fat, T1, bright fat, you see this enlarged superior ophthalmic vein. The size is quite large. On the left side here, you barely see, but in this image, in this, next cut, you see this are normal, superior ophthalmic artery. So this is very big. Even before the contrast, you see that fistula already here. So now, in conclusion, now we talk about the AVM. AVM, the nidus are very tight, nidus, no intervening normal tissue. Usually one large feeding artery and one early large draining vein. This is the typical feature there. For proliferative angio, it's it might look like diffuse type of AVM. But they are quite different, histologically. They are very diffuse, very, very large vein, nidus, with ill-defined margin there, and you don't see one prominent feeding artery. Usually they are supplied by 2 or 3 feeding arteries of mostly normal sized feeding arteries, and you don't see early draining veins. This is the characteristic. Fistula. Now we talk about dural fistula, which is the second most fistula, abnormality, and we talk here pia fistula, very rare. So what I show, those cases are from the literature. Okay. Next, we always frequently see this CCF fistula. We are very familiar with this. We frequently see CCF. Next one are vein of Galen malformation. Now this is the developmental malformation. Location vein of Galen location. You see a dilated vessel there, because of the fistula. So feeding artery, embryonic, choroidal artery, which has anterior choroidal artery, posterior choroidal artery, the arch, the anterior cerebral artery, or arch supply lobe. It drains into prosencephalic vein, which is the precursor of the vein of Galen there. So this is the conclusion of my presentation for this morning now, and I thanks for everybody. watching this presentation.